This film is about how the quality of social work in mental health can be enhanced by complementing line management supervision with clinical and professional supervision.
Relatives or carers of people.
The social workers in this film are all members of a multidisciplinary mental health team at the Norfolk and Suffolk NHS Foundation Trust.
But if you visit the home and there are still any concerns, they're really quite open to comment in terms of how to improve their service.
They work with extremely complex cases in residential care homes, and good supervision is essential to ensure high standards.
Supervision is absolutely crucial. We sometimes make mistakes, we overlook things, we're not always as thoughtful if we're running around without actually that time to reflect, to sit down and for other people to ask questions of how we're carrying out our duties. We sometimes just carry along without making assumptions, and I think it's very healthy to stop and reflect, and line management and clinical supervision asks staff to do that.
Please feed back to me and I can feed that back to them. I know
the prime focus of the team is to enhance the recovery and independence of residents.
Okay. Hi, how are you?
Yeah, not too bad, thanks.
Good. Before we start...
It's a policy strongly underpinned by supervision. James, who's in his second year of social work, is having his monthly management supervision with line manager Kareen.
Can you sort of advise me what your caseload looks like at the moment?
It's probably just above 60, I think.
Okay.
And I think of those, I've got about 10 people who are kind of in that red zone, more challenging.
I think from the management supervision point of view, it is much more about performance, making sure they're fulfilling statutory responsibilities and duties, that they're following procedures and protocols that are embedded within both the trust and within social services. Last week I attended a meeting where they presented the data performance for the locality. It's very important that the cluster pathways are completed.
In addition to management supervision, Norfolk and Suffolk have what they describe as clinical supervision once a month. In practice, this covers clinical issues such as developing knowledge and competence, and professional issues such as reviewing the work carried out with people. When different aspects of supervision are being delivered by different supervisors, clear communication and lines of responsibility are crucial in order to ensure significant information about a case is shared.
In terms of clinical and management supervision being done together by the same person, I have in fact done that in a previous post when I worked in older person services, and it was done as a bit of a shorthand, and I think because people were feeling that they were short for time, so we'd just lump it all together. And in actual fact, I think all it ends up being is management supervision. If the manager is doing the management supervision, the clinical supervision just goes by the wayside. It's a bit of an afterthought, and I think that staff are then done a disservice. They lose out on an opportunity to be thinking about their practice, thinking about developing their skills.
James's clinical and professional supervisor is Simon. Simon is a senior social worker and an approved mental health professional, who also holds a Practice Educator Award.
So I guess it would be helpful just to start perhaps with a bit of an agenda, really. Mm-hmm. I mean, we've got our kind of set features that come from the policy, so kind of we'll talk about safety, assessment and formulation, reflecting on clinical relationships. So I guess we've got to cover those, but are there any particular cases or pieces of work you've done recently that you feel are significant or have you found challenging at all?
Yeah, and there's one case, a guy called Peter. He's a guy with a diagnosis of Asperger's syndrome and schizophrenia. I mean, he's getting command kind of directions from the television, making him do things. So he takes his top off and puts it back on again, kind of constantly.
In terms of Peter's communication style and his routines, how have you come to get to know those? Are there people that you've spoken to, or is there particular work you've done with Peter around that?
Obviously the care team around him, because they know him very well and they have a really good understanding actually of what his routines are and how what he likes, which obviously with communication is important, particularly because the way his presentation is, he becomes very agitated at the moment about things, and he's very repetitive in what he talks about, and he'll talk about.
Peter is currently based in intensive psychiatric care, and Simon is helping James to explore ways to help Peter become more independent, so that he can eventually move into a residential home.
And the other thing is he really hates formal meetings. So when we have, obviously we have reviews on the ward, which we have, you know, lots of different professionals attending, and it's important that he's involved in those discussions, but actually that makes him really, really distressed, and it's really difficult to get anything from him. So it's quite a careful balance that needs to be struck between getting him to actually attend or to feed into that process without actually pushing him, sort of making him worse again.
Because what might be kind of reasonable adaptations, I guess. I mean, I know that really is in the sense of physical stuff, but for example, I mean, on the ward, you picked up on the review, and actually, yes, there's a standard format for the review, but actually, if we know part of his condition means that kind of group communication that doesn't take the very specialist format that you adopt, is distressing for him, then actually using that method unadapted is actually excluding him. And I just wondered on that theme whether there were kind of reasonable changes that could be made to usual processes or procedures or usual care planning that would perhaps make things more person-centred, more recovery-focused. And
I think that's quite a good point. I mean, it is quite a rigid structure. I mean, I certainly think that it might be easier to have somebody speak to him beforehand, you know, maybe have quite a clear agenda that's gone through it.
Line management supervision, we've got a very clear template that supervisors are expected to follow. They can add their own stuff in, but there is a template that covers key areas around performance, workload, well-being, those sorts of things. There isn't a requirement, there isn't a template for clinical supervision that's much more free, although it is expected that it's recorded in some shape or form, although those notes are confidential. We wouldn't be calling on those to be looking at routinely. I guess in it they will hopefully be thinking about professional competencies, and they would be using stuff like HCPC, but there isn't any strict guidance. I think that depends on very much the relationship between the supervisor and the supervisee.
Another difference between Norfolk and Suffolk's clinical supervision and management supervision is that the supervisee can choose their clinical supervisor. For social workers, this is especially useful if their line manager is not a social worker.
In mental health, we often find that social work staff are supervised in line management supervision with a nurse who might be their clinical team leader. And although that works on a performance basis in terms of line management, for clinical, it's often better if people are seen by their own profession, because there's a greater understanding of the duties and the roles and responsibilities that come, for example, with social care.
I find it really useful having the two different types of supervision, because I think that the line management supervision is it's about what the organisation wants and what the organisation requires of me, whereas my clinical supervision is about what professionally developing me as a professional, which is something that's quite different actually, and obviously that allows me to kind of have two perspectives on what I'm doing.
And I guess just finally, are there any particular social work theories, do you think, or any kind of evidence-based practice do you think that you've kind of brought to this case, or that might have applied perhaps?
I think in particular it's kind of understanding the systems that are working around Peter. He does exist as an individual, but also within this kind of matrix of kind of systems, and the other patients and the ward environment, how they impact upon him and how he impacts upon them. Kind of understanding those things is quite crucial to understanding why his presentation is as it is, understanding the environment.
I think working in a mental health trust, it can be easy to lose social work theories. So James had an ability to actually identify a social work theory that looked at the environment somebody's in and the interrelationship between the person and their setting and those people around them. And that's really valuable to understanding how somebody, in particular with Asperger's, may present with distress. For example, if his needs aren't met on the ward, it would be very easy from a mental health point of view to see that as solely a case of clinical symptoms. And I think James's ability to bring a social work theory to that and to understand how the broader setting may be contributing was really valuable. And it also allows him then to potentially challenge issues of power, discrimination, for example, in terms of how review reviews happen on the ward. I mean, that was just one example of how a particular process can cause this service user distress.
As a social worker, I always want to sort of sit somewhere between the service user, the organisation and the profession, and I want to, there's sort of things which are constantly having to be in balance. So if I had the supervision simply with my line manager, I might end up being drawn more towards the organisational needs rather than considering the kind of the wider aspects of what a service user might need or what in fact might be good practice.